Losing weight is very unnatural. Like when you think about it, what are some of the biological reasons why people would naturally lose weight? Really, it's only in the presence of a severe disease or deprivation of resources.
Fat cells are actually metabolically active. Like these cells are alive, and now they're further impacting the whole cascade of everything.
We actually have data now on the impact of cardiac events with GLP-1s.
I'm not here online, neither is Linda, trying to say you're obese and that's your problem. It's not a personal failing, and real solutions take more than quick fixes or celebrity shortcuts.
Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same.
This is going to be a super awesome episode. Please stay tuned. We're going to be talking all about obesity and obstructive sleep apnea, that relationship, but we're also going to get more nuanced on this episode with Dr. Linda Anegawa. She's going to be sharing with us some really practical approaches to how these medications are deployed in clinical practice. And I think this is helpful for both patients and providers to stay tuned. So please don't turn off. You're going to learn a lot if you stick around. So without further ado, Linda has a number of accolades after her name, and I'm not going to list them all here in the interest of time, but she is quite literally, and I mean this, quite literally, one of the foremost voices in obesity and metabolic health. She has over 2 decades in both academic medicine and hands-on patient care, and she is the current CMO and Chief of Metabolic Health and Obesity Medicine at Ognomy Sleep, the former Chief Medical Officer at Noom. Heck yeah, I have the former CMO of Noom on my podcast. Duh. This is pretty awesome. I'm telling you to stick around. She's pioneered clinical weight loss programs that blend technology, medical insight, and compassion. That is exactly what she is doing at Ognomy, and I'm really, really proud to get an opportunity to work side by side with this brilliant brain who's going to basically make me smarter and make me a very effective clinician in the sleep medicine space, utilizing weight loss medication to help my patients. So I'm very excited about my future with Ognomy. So her approach is clear. Obesity isn't a personal failing. That's important, guys. I'm not here online, neither is Linda, trying to say you're obese and that's your problem. It's not a personal failing, and real solutions take more than quick fixes or celebrity shortcuts. She has been featured everywhere. She's been on Forbes, Oprah Magazine. She is advocating for science empowerment and the end of weight stigma in healthcare. So welcome, Linda. Thank you so much for joining me today.
Allison, thank you. That was too kind. I think we have a mutual admiration society going on here. So yeah, really honored to be able to chat with you.
So we know that obesity and OSA are linked. There is this bi-directional relationship. From the obstructive sleep apnea perspective, we know that about half of patients who have sleep apnea, one of the primary drivers of that sleep apnea is indeed that they are heavy, because we start to get fat deposition not only around our middles, we get it around the neck, we get it in the tongue actually collects fat. And, you know, if we have a big neck and a bigger tongue, that leaves very little room for us to be able to breathe properly at night. But conversely, sleep apnea also can kind of marry in and contribute to the obesity epidemic that we are experiencing in this country. And I was hoping that you can enlighten people on the relationship between how OSA may potentially continue to be an ongoing driver for obesity.
Yeah, absolutely. Like you mentioned, bidirectionality is very important for people to understand. We know that disrupted or fragmented sleep or lack of sleep, such that occurs with OSA, actually has metabolic consequences. And that in turn can worsen obesity. So, you know, as a sleep medicine doc, obviously, you know that sleep fulfills some very important functions for us, right? Like the energy conservation, the tissue repair, the cognitive, the emotional processing. But also, we don't think about sleep as being critical for the regulation of many of our hormones. And in particular, when we talk about, say, and obesity, fragmented sleep in particular we know leads to low leptin levels, which is our satiety hormone or one of the satiety hormones. And it can lead to increased ghrelin, which is one of our hunger hormones. And it actually doesn't take much sleep fragmentation or sleep deprivation even. We know that a disruption of as little as 1 hour a night on 5 days of your week can lead to this. The OSA will definitely worsen obesity over time. And then that obesity in turn is going to also make comorbid sleep disorders like OSA worse. And it will make management of OSA much more complex. So I think that's why it's just so important to try to optimize weight health in our patients any way that we can, because it will improve pre-existing OSA. It can even prevent or reverse it in some cases. And we're really aiming for 7 to 9 hours of good quality sleep when we're looking at promoting optimal weight health.
And I love what you're saying about timing, because one of the things we also know about obesity is obese people tend to not be able to sleep for long periods of time. So it's so common that I see the obesity actually impacting sleep time. And a lot of the patients I see are like, well, I only sleep like 5 hours. And I'm like, oh boy, here we go. We've got to try to reverse this. And we would not have developed drugs for this if we didn't know that just having someone in the office and going, oh, you're getting exercise a little bit more and restrict what you're eating, and very bland advice that we're often left to giving to patients, and being able to be more prescriptive in 2025 about what we're actually counseling patients about, I think is so huge. And that leads to the next thing I want to discuss, which is we know we are seeing a major shift moving beyond blaming people. Like, hey, you're just heavy because that's, a problem. You just are indulging in too many sweets or eating too many salty things, and you've got to decrease your caloric intake. I love that we're starting to look at obesity truly as a disease process that is very real and very complex. This isn't just a lifestyle issue. This truly becomes a true condition, a medical condition, just like high blood pressure or obstructive sleep apnea or any of the other major medical conditions that we classify. But pop culture and social media still love to judge and assume anyone who loses weight and did it the, quote, wrong way. So can you explain to my listeners, why is losing weight on your own so difficult?
Yeah,
and what do
sure.
most people misunderstand about obesity and willpower? Because I think that's really getting to the crux of that judgment. And honestly, I think a barrier for people who are obese to even want to talk about it, because they don't want to go to their doctor or their healthcare provider and feel like someone's talking down to them and making them feel bad about who they are. That is a very, very difficult discussion to have.
Yeah. Well, let me just say one quick word about willpower, because this is always one of my favorite things to talk about. So we can't use willpower to drop our blood pressure, or if we have type 2 diabetes, to drop our blood sugar. It doesn't work like that. And in the same vein, we also cannot just use willpower to fix the disease of obesity. Now, having said that, all of these metabolic diseases certainly have lifestyle factors that can influence the course of the disease, right? So for high blood pressure, if you reduce salt, if you exercise, blood pressure can come down, just the same way as increasing your physical activity can prevent further weight gain. So I want to make that very, very clear right from the start. And I think in terms of getting to your question, why is losing weight so very difficult? The simplest way I can explain it, and I always tell patients this, is we evolved as human animals to conserve our weight. Right? Losing weight is very unnatural. Like when you think about it, what are some of the biological reasons why people would naturally lose weight? Really, it's only in the presence of a severe disease or deprivation of resources. For example, we all talk about cancer cachexia and how people just dramatically lose so much weight with cancer. So if you think back to, prehistoric humans when we were living in caves and when we had to hunt and kill antelopes and climb coconut trees and forage to get our food, our bodies evolved to do a few very, very basic things. So we evolved to sleep and we evolved to conserve our weight just so we can reproduce, right? And carry on the species. So that's one thing that I think folks should understand. Now, the tricky thing too is in our modern society, when obviously we have access to any food that we choose, and in our obesogenic environment, a lot of this is very highly palatable, high caloric, high sugar, high fat foods, it's far easier for us to gain weight. We're set up for that biologically, and then we're put into this obesogenic environment. And then once the cycle of weight gain begins, one of the things that we're starting to understand is that fat tissue doesn't just kind of sit on your body doing nothing. Our fat cells or our adipocytes are very, very important endocrine and immune organs, as it turns out. But
wow.
with progressive weight gain, they become dysfunctional. They secrete much more inflammatory mediators. They cause hormonal disruption that is going to further that cycle of abnormal weight gain. So, it's like, even if someone loses weight, which is great, you can regain easily. And it's driven by a combination of these neurohormonal, biochemical, behavioral, as well as psychological mechanisms as well. Like, I think one of the things that can definitely happen to folks is that there's a mindset that we get into where we're thinking, okay, well, I lost the weight. Now there's not much I really need to do to keep it off. And that's what I'm talking about when it comes to the psychological components and the behaviors that, reinforce the healthier, lower weight, if that makes sense.
Yeah. These, by the way, I've never heard it put so succinctly. So I'm really excited to be able to blast this across social media because I think a lot of people need to hear it. I mean, I didn't think about the fact that the fat cells are actually metabolically active. Like, I know I've heard of that, but it skipped my consciousness as far as when I'm having a dialogue with someone. And the fact that you just put it to the forefront of my mind, I'm like, oh, snap. Yeah. These cells are alive, and now they're further impacting the whole cascade of everything. Mind blown.
That's right.
I want to talk a little bit about the judgment that sometimes comes across that is still pervasive. So I'm thinking about Hollywood, for example. This seems to feed the myth that there's like some sort of a shortcut and that people who use medication for weight loss are somehow, quote, cheating. And that really is a bias. It's misinformation. And I wanted to know if you could comment a little bit on that, because I think we need to really stop making people feel bad that they may be on these medications for weight loss and be ashamed of that.
Hollywood has a very powerful influence. I think social media has a very powerful influence when it comes to perpetuating myths. I think we could sort of look at this in two different ways, right? So you mentioned the blaming and the shaming that drugs to treat the disease obesity are a shortcut. And this was the way some people used to speak about bariatric surgery a generation ago, even 5-10 years ago, right? So I think it kind of, goes back to what I was saying before, that it's critical for us to educate on obesity as a disease state. We got to keep doing that. We have some really great advocacy groups, such as the Obesity Action Coalition, that I think do a really wonderful job. And their website is available to anybody. You can just Google them. But they have a lot of educational materials that I think are really helpful. But also we need to educate our practicing doctors. We need to educate any clinician really going into medicine on this, because I still think we're not doing the greatest job. And then, like dovetailing on this as well, and sort of another side of the coin that bothers me, personally and as a physician is, when we talk about Hollywood, you see all these celebrities of normal weight who are using GLP-1 medications to achieve excessive thinness. And I think that is disappointing to me, because like when I was a teenager in the 80s, those very thin, waif-like, starved appearance models on catwalks were all the rage. And then it was kind of nice to see things swing the other way, where we embraced the natural beauty of bodies at all sizes. And we weren't talking so much about numbers on the scale, but are you metabolically healthy? Is your blood sugar okay? Are your lipids okay? Is your blood pressure okay? Right. So I think just separating appearance versus metabolic health, I think, was very important. And I worry that now we're kind of going back the other way. So while I am a huge fan of this drug class, and I think that they are very, very powerful drugs to be used in treating the disease of obesity, I also worry that they have the potential to become their own disease, if that makes sense. I like to discuss this with patients, especially in anyone who has a history of any disordered eating or body image concerns, or seems like excessively focused on what they look like.
To that end, is it possible to have a body mass index, which is how we kind of base obesity class right now? And there's arguments to be made. Is that even accurate, especially in our sort of very muscular population who muscle weighs more than fat? And so they may appear very muscular, but their body mass index, it's like, hey, your BMI is 30. I'm hard pressed, but I've seen it a lot. Like I've seen CrossFitters and weightlifters and things of that. Is it possible to technically be, quote, obese or have a higher fat content? So I'm not talking about the six pack, everything is muscle person, and be, as you mentioned, metabolically healthy. And what do we look for that determines your metabolic health? You opened up that Pandora's box of questions, and I'm dying to know. I think I never thought about it that way. And so I'm really happy that we get to discuss it.
Yeah, no, 100%. I think you hit the nail on the head, Alison. BMI is an incredibly flawed tool. The interesting thing is it was originally conceived as a research tool just because it was quick and easy to measure, and it became adopted into clinical practice. But you're right, it tells us nothing about body composition. We know there are obviously gender differences. There are racial differences as well that can be very, very misleading and can misclassify individuals with the disease of obesity when, they live in a larger body and they're perfectly healthy. So looking at things like, are there risk factors for cardiovascular disease? Is there dyslipidemia? Is there insulin resistance? Is that individual suffering from what we would call fat mass disease, which is the abnormal physical forces that result from carrying excess adiposity? Like, for example, osteoarthritis of the knee is one of those. In the absence of all that, and this is what I like about a particular classification system that we often use in this specialty, which is called the Edmonton Obesity Scoring Index. And so it's not so much based on weight, but do you have comorbid conditions that go along with the disease of obesity that increase your risk of progression and even early mortality? What you'll start to see in many clinical practices, especially smaller practices, doctors starting to use, for example, body composition, using a body composition analyzer to measure body fat. Because yes, you can have a normal BMI and be metabolically at extremely high risk based on your body composition. So very, very important to keep that in mind. And I think what's kind of unfortunate is that the FDA approved indications for GLP-1s have all been framed around that BMI, and that could potentially lead to overuse in people who simply live in a larger body, and it could potentially lead to underuse in a lower weight individual who is at very high metabolic risk.
That is fascinating. And I have never heard of this Edmonton scale ever. So this is the first, and I would love to see us moving toward what you, I think, ideally would like to see amongst all of us, not just obesity medicine specialists, but us really looking at the obesity problem as a disease process that we feel very comfortable with. Because I think that is also one of the barriers is I'm so excited to be at Ognomy because I know I have a Linda at my fingertips. Like if I'm like, okay, I'm ordering this, I'm not quite sure. What do you think the best course of action is? I can just ask someone But a lot of people are out there going, well, I don't have anybody to ask. Are there any resources for people to actually learn how to be better at utilizing these medications more responsibly?
Yeah, absolutely. So the Obesity Medicine Association has a whole suite of CME courses that are affordable and kind of walk clinicians through all of the basics. They even have periodically these like half-day seminars, like Introduction to Obesity Care for primary care doctors, for example, that I think are very informative and very helpful and can help kind of build your own confidence as a clinician. Another one that's really good is called the SCOPE, SCOPE, World Obesity Federation, which is an international organization that has sponsored CME, very inexpensive, and they'll certify physicians only, but the SCOPE credential can be earned by any clinician that treats obesity, whether you're an MD, PA, NP, RD, even a bariatric psychologist can earn that credential. And I just love that because I really feel like the more of us who gain a better understanding of treating this as a disease, the better job we will do, the better job we'll do prescribing, the better job we'll do counseling, the better job we'll do with outreach and education.
And so there is a way to actually get a certification that shows that you've actually established a competence in this area without actually having to do a separate obesity medicine fellowship or go through board certification and all of that is what I'm hearing from you.
The ABOM, you do have to complete a certain number of CME. You have to attend. I can't even remember what the requirements are. It's been such a long time now, but you have to attend a certain number of in-person meetings. And there is an exam. So that's the physician one. The SCOPE can be done entirely online. There is testing that goes along the way with it, but it's not intimidating. It's very doable. I've done a whole bunch of it. I confess I have not finished my SCOPE credential, but I was checking it out on behalf of some of the clinical team. But it's really, really good.
That is so key because I have even heard of people being like, well, I kind of think I need to get an extra. And listen, if you're interested in doing that as a clinician, I'm not going to tell you not to go on and get those credentials. But for a lot of us, and I can say for myself, especially if I'm just maintaining 3 board certifications, the idea, I want to be very proficient and be very good at what I do. I think it's so important for me intellectually, as well as the care of the patients that I give. I want to be able to really have a good relationship with my patients. And I think these extra coursework and knowing that existed, I didn't even know any of this existed, is very, very helpful. So I appreciate you, but it also lets me know I don't necessarily need to stress out about having some specific whole other board that I need to sit for if that's just not in my mental bandwidth. And I think a lot of us are, especially as so many of us are still in a clinical practice model where we are using insurance plans and we have to kind of create a business structure that keeps us surviving in that increasingly complex medical environment. I think the struggle for some people is going to be, man, I got to fit in more. Oh, it almost feels very intimidating.
Absolutely. But I think, on the contrary, Alison, I feel like the more knowledge and the more background, the more understanding you have, it actually makes things easier in a way because you can zero in more quickly on those key points. So for example, like, what do I really need to know about this patient to facilitate prior authorization of their GLP-1, right?
Ooh.
Yeah, right. So it's the stuff I don't really like so much, but we need to be cognizant that like to treat these patients, we need to get their insurance to pay for it any way we possibly can, because these are not cheap, as you know.
Yeah. And I will tell you, any sleep doctors listening know exactly what we go through and all the little check boxes we know to get our patients treated for their sleep disorders. So we are very much aligned. And what I'm also realizing is I'm going to need to get much more well-read in how to navigate the new hurdles that we have with GLP-1s. And I think a lot of other sleep specialists are in the same camp. Switching gears, we're talking about GLP-1s. I wanted to get your take on how the appropriate way to dose is, because you have what we know, and I'm going to focus on the SURMOUNT-OSA trial simply because that's what I know the best, but there's been many other trials from Eli Lilly. I'm also emphasizing that particular trial because it's tirzepatide, which is approved for obstructive sleep apnea, though there are many other GLP-1s that may not have the OSA indication, but are indicated for weight loss. Generally speaking, they're using this as an example, but I'm assuming it can apply to other GLP-1s. They talk about the stepwise progression. You start at 2.5, and that's really the introductory dose. You have a dose weekly, and you do that for 4 weeks, and then you increase by 2.5 each week. But I've heard of people talking about microdosing GLP-1s, and I wanted to know your thoughts on that, because in my mind, it makes the most sense to use the lowest dose possible to mitigate side effects. And how do we monitor when we need to go up on dosing? So please help me out.
Yeah. This is kind of like two separate topics to me in a way.
Okay.
The first thing I will say is that, yes, we always want to start with the lowest dose possible to minimize the chance of side effects and to increase long-term tolerability. That being said, a couple things. The first is that I have had patients who lose weight beautifully on the starting doses of these drugs, and they end up not needing a higher dose than that. Or if we try to titrate them up to the next dose, they have intolerable side effects. And then they're like, I can't do this. I'm done. And I don't want that. So I would rather keep them at the lowest tolerated dose possible, as long as they're doing well and they're losing weight. I always teach clinicians, personally, I don't feel like we should pressure our patients. Like, well, it's not going to be good unless you get up to what they call the treatment dose, right? Because in my clinical practice, I just haven't seen that. And every person in front of us is a different human being, right? So that's one thing I want to say. In terms of microdosing, well, previously to us having the auto injectors that we have for Wegovy and Zepbound, like on the old Ozempic pens, which of course are FDA approved for type 2 diabetes and not weight loss, and on the old Saxenda pen, liraglutide, our sort of first generation GLP-1 back from 2012, you could actually turn the pen by fewer clicks if you didn't want to get fully to the starting dose. And even though this is not an FDA approved way to dose the medications, I have had patients who I have done that in. For example, a patient with severe diabetes who has a history of gastroparesis. In general, like, I'm not thrilled with putting people with gastroparesis on these drugs, but in some patients, they're at such high risk. Like, I'm talking about individuals with an A1C of 10 and they're on 3 other agents and their BMI is 35. It's like, wow, well, we got to try this. Otherwise, we're taking you to bariatric surgery. So I have taken the opportunity in some of those cases to say, okay, well, we're going to start with just 10 clicks of the pen rather than going up to 20 clicks to get to the starting dose. But that being said, what I don't like out there is that we have a lot of GLP-1 compounders who are using the microdosing argument by saying, well, we're personalizing the drug for users. But they're really not, because what they're actually doing is mass producing doses of very, very small amounts. And that's not the way compounding was meant to be used, right? Meant to just personalize a dose for one single individual. Plus, the compounders are using molecules that many times are only approved for research, like their research grade, or their composition, purity, potency cannot be verified, or they're mixed with a bunch of other things that have very little evidence for any type of benefit in obesity care. Like the one I see all the time is like vitamin B12, like they mix it with that. So in that sense, I am extremely skeptical of microdosing. I always tell patients too. And actually, if you've heard of Dr. Angela Fitch, she is a very, very well-known academic physician in obesity medicine, Harvard faculty, founder of a service called Known Well, which is weight inclusive primary care. She calls it the largest uncontrolled, unconsented human clinical trial in history.
Wow.
Yeah. And I agree with her 100%.
That is fascinating. So we're now achieving weight loss. We're on our trajectory here. What's the end game? What do people need to really recognize about this medication? I think it gets to the idea that it can really be, I've heard it described for people that are on it that have never been able to actually take that weight off as sort of a miracle drug. But it's a miracle drug that, as far as I'm aware of, really is more of a long-term solution. So this is something that you continue to work on your lifestyle and doing all the right things. But in addition, you can't necessarily just stop the medication. Am I understanding that correctly?
Yeah. So, I mean, just thinking about obesity as a disease state, it's really not going to be different from, something like hypertension or even sleep apnea necessarily, right? Like you're going to need treatment for that over the duration, right? It's not something you can just snap your fingers and make go away. And you brought up the SURMOUNT trials. And when we look at that data, it does show that people who stop the medication seem to regain most of their weight. Now, like one thing I will say about that, it's really not clear to me how much lifestyle support those individuals in the SURMOUNT trial got after their medication was stopped. I always tell my patients, I always tell clinicians that medication is really just one pillar that is needed to support an ongoing healthy weight, right? So it's medication, it's behavioral change, it's nutrition, it's activity, stress, sleep management. All of these things are very, very important. So, I've always kind of wondered about that personally. I mean, I do counsel patients that this is a long-term problem that needs long-term treatment, but I have always wondered about that. And then, the other thing that's kind of interesting is we're starting to look at more real world data out there, post-marketing analyses. And these are not necessarily published by the pharma companies themselves who typically sponsor the initial trials, but there was a very large retrospective study that was published showing that people maintain about a 5% weight loss a year after they stop semaglutide and liraglutide. There was also a study put out by Virta Health last year. Virta Health is a virtual telemedicine and coaching platform focused on metabolic health, specifically diabetes treatment and prevention, but also weight management. It was a smaller study, I think about like 150 people in it. And what they do is they put individuals on a carbohydrate restricted diet along with intensive telemedicine coaching. And so what they found was that I think like close to 80% of their study participants, even 12 months after they stopped the drug, were able to maintain at least a 5% weight loss. So these are all interesting. So they do need more validation, these type of results. And, I'm very excited to see more real world data as we go on. But, the other thing that I always tell my patients too, kind of going back to what we were talking about before, how our bodies evolved to conserve fat. I mean, life is going to happen, right? We're going to have unusual stressors. We're going to have travel. We're going to have periods of poor sleep. We're going to have like Thanksgiving and the holidays, right? So metabolic adaptation is always at work. So ongoing weight gain is always going to be a possibility. And even if I have a patient who wants to discontinue their GLP-1 therapy, I'm happy to work with them on that. But I think we also need to set the expectation that we need to be prepared to step in again with pharmacotherapy, right? Just like with blood pressure, as you brought up before, Allison, if a person, let's say, is able to come off their blood pressure medicine because they reduced salt, they lost a little weight, and now they exercise, well, that blood pressure can go up again at any time too.
Right. I think that's a really good point. In terms of the dosing structure long term, a friend of mine who actually started an obesity clinic in Alabama, he's a cardiologist, but as you can imagine, he's seeing a lot of big people in Alabama, and he's needed to be aggressive about being able to manage their weight because he wants to lower their cardiovascular risk, which is another topic of discussion here that I do have a question about. What he mentioned to me is over time, once people sort of reach the set point that he feels is like a healthy weight for them, he does try to start to sort of decrease the dose. Is that something that we should be aiming toward, is saying, okay, you're now at your ideal body weight for you. This is kind of where we're planning on staying with you. What happens next? Do they continue the same dose? Do they decrease it over time?
Yeah. I don't think we know exactly, Allison. So you'll see a lot of variability in clinical practice on this. And I think it's somewhat of a, it's a little bit of artsiness here and shared decision making with the patient. Certainly if a patient is at a weight that they feel comfortable at and want to maintain, I will tend to look at things like, well, what other medications are they on? What kind of side effects are they having from the medication? What's the affordability of the medication for her? Like if they have no drug coverage and this is really putting them out financially every month, we want to do the best we can to reduce the dose as much as we can and even potentially taper them off. So optimally for weight maintenance, we don't really know yet. What is interesting is that we're about to see in, the next probably 12 to 24 months, approval of some of the oral GLP-1s, which may not have as large of a percent of weight loss in the clinical trials as some of the injectables. But it does beg the question, well, if the orals are less expensive and it's easier to manufacture them and they're more available, could those be an important weight maintenance tool for patients? And, I think they certainly could be, but we won't really know until we get them out there and start to see how they work in the real world for patients.
Well, I hope they have less side effects if they're orally available, or, especially when it comes to some of the nausea and the vomiting that you sometimes hear people have to endure. The other question I had for you that you made me think of was just really about the major adverse cardiac events. So we're talking heart attacks, strokes, abnormal heart rhythms, things like that, serious issues that can happen that we know are associated both with obstructive sleep apnea as well as obesity. Do you have any thoughts on that in terms of the impact of GLP-1s on those major adverse cardiac events?
Yeah. So, we actually have data now on the impact of cardiac events with GLP-1s. I think it's one of the reasons why we're just going to see GLP-1s utilized so much more broadly and for additional indications rather than just sleep apnea. So by reducing weight, by improving some of the metabolic risk factors, by reducing epicardial and pericardial abnormal fat deposition, we're going to have a very, very big impact. And I know this question always comes up because cardiovascular disease is so costly to treat, and people are always trying to balance the cost of the medication with the cost of treating the cardiovascular disease. There's a lot of active research going on to try to figure out and to really show payers and show employers that it really does pay to treat people to reduce those downstream consequences. You already know, right? Just separately from GLP-1s, just like taking them off the table for a second, that treating sleep apnea is associated with cost savings down the road. We definitely have data on that. So now we just need to figure in, the cost of medications for individuals with sleep apnea and do those analyses as well.
Thank you so much for your time today, Linda. This has been really a wonderful pleasure. I have learned so much from you, and I know anyone who's listening has as well. Do you have any final words as we wrap up?
Yeah, I think some of the final things that I think are important to just emphasize about the drug class. I think they're a very powerful tool. I want to re-emphasize, though, that they're not necessarily a panacea and that other pillars are very, very important to support long-term weight health and long-term general health. I think it's really critical to be supervised by a physician or an experienced clinician who's going to monitor you ongoing, one-to-one to make sure, number one, that you're using the medication safely, but number two, to really make sure you're getting what you should be getting from these medications, or at least as much as you possibly can.
Linda, thank you so much for your time today. If you are interested in talking with me about your obstructive sleep apnea, Linda and I both work side by side at Ognomy. And like I said, I have an obesity medicine specialist at my fingertips. So I feel very confident in being able to kind of work with you regarding your sleep apnea. One of the things that Linda and I had kicked around was actually having a discussion a little bit more about GLP-1s that's specific to obstructive sleep apnea. In the interest of time, I think that might be a part 2 conversation. But for right now, if you are interested in working with a sleep physician who will also keep your obesity in mind, feel free. I'm in 4 states and we have all 50 states covered in Ognomy. It doesn't need to just be me. Okay. So please check it out. It's sleep telemedicine. It's very convenient. It's an insurance-based organization, so we do indeed work with you and your insurance to the best of our ability. And as much as your insurance wants to cooperate with us too, there's part of that.
That's the key,
So
right?
thank you so much for staying tuned. I know all of you listen to the very end. Hint, hint, wink, wink. Make sure to comment, subscribe, and share this with someone who needs to hear it. Thank you.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.